The human heart operates as a continuous, relentless pump, expanding and contracting roughly 100,000 times a day to supply the entire body with pressurized, oxygenated blood. Like any high-performance engine, this biological pump relies on its own dedicated fuel lines to keep running. In the body, these are the coronary arteries. Over time, these critical pipes can become choked and narrowed by atherosclerotic disease, severely restricting the flow of fuel to the muscle. To bypass these blockages, surgeons must perform precise plumbing reroutes on vessels that are barely 2 millimeters wide. And they must figure out how to execute this microscopic splicing on an actively firing engine, constantly twisting in space and filled with fluid under high pressure. The solution to this is coronary artery bypass grafting, or CABG. To repair the blocked vessels, surgeons harvest biological spare parts from the patient, intentionally take the central cardiac engine offline, and temporarily hand over the work of sustaining life to a network of external machinery. This makes CABG a high-stakes engineering feat, a process of dismantling and rebuilding a primary system where any sustained failure is catastrophic. The raw materials for the new plumbing are gathered first. Surgeons harvest spare conduits from the patient's own body, extracting the long saphenous vein from the leg, or carefully dissecting the internal mammary artery away from the chest wall. To safely install those parts, the patient's blood is heavily thinned with heparin. This vector diagram of the circulatory system shows blood completely diverted away from the heart. A cross-clamp is applied to the aorta, and cold cardioplegia solution is injected, arresting all electrical and mechanical activity until the organ lies completely still. During this window of suspended animation, the harvested conduits are grafted into place. The surgeon anastomoses, or sews, the new vessels to the coronary arteries at a point distal to the stenosis, creating a clear detour around the blockage. Shunting the entire blood volume out of the body and through a plastic circuit secures the one condition required for high-precision reconstruction: a stationary, perfectly bloodless environment. Relying on the cardiopulmonary bypass machine introduces severe mechanical risks. Clamping the aorta and running blood over non-biological plastic surfaces can cause atherosclerotic debris or clots to embolize, leading to a stroke in approximately 2% of patients. To eliminate the need for the bypass machine entirely, surgeons can use an off-pump technique. They apply mechanical stabilizing devices like the octopus, which press down onto the beating heart to physically lock down a tiny isolated square of tissue, while the rest of the muscle violently contracts around it. Another alternative is minimally invasive direct coronary artery bypass, or mid-cap. This technique avoids the massive median sternotomy incision, mitigating the risk of deep sternal wound infections, a complication that occurs in up to 2% of patients and carries a mortality rate as high as 40%. These alternative techniques operate as calculated risk mitigation strategies. They force the surgeon to accept a bloody, moving field, trading optimal visibility to prevent deadly systemic complications. Returning to a standard bypass, the most critical phase is the reboot. The aortic cross-clamp is released, and warm, oxygenated blood floods back into the stationary heart muscle to initiate reperfusion. The primary point of failure occurs right here. Myocardial function typically declines in the first few hours after the surgery, as the tissue reacts to the sudden return of oxygen, a phenomenon known as ischemia-reperfusion injury. If the pump struggles to restart, the first line of defense is chemical. Physicians administer inotropic agents like dopamine or adrenaline to artificially increase the heart rate and force the muscle to contract harder. If the low output state persists, they deploy the first level of mechanical backup. This is the intra-aortic balloon pump, or IABP. This cross-section shows an intra-aortic balloon pump sitting in the aorta. It rapidly inflates during diastole, the resting phase. This displaces the blood, forcing it retrogradely back down the aorta to artificially pressure wash the newly grafted coronary arteries. If the heart still fails to generate enough pressure, the final failsafes are deployed. Surgeons can install continuous flow ventricular assist devices, or VADs, to mechanically pull blood through the chambers, or place the patient on ECMO for total extracorporeal life support. This escalating hierarchy of backups secures the procedure. It guarantees that the circulatory system remains pressurized and flowing, even if the organic pump initially stalls during the reboot. Once the heart stabilizes, the patient is transferred to the intensive care unit. Over the next few hours, they are extubated as external supports and monitors are incrementally withdrawn. The first 24 hours present distinct physical hurdles. Around 30% of patients experience electrical misfires, like atrial fibrillation, and 2 to 3% face significant internal bleeding that can require an emergency return to the operating room. The postoperative window is a volatile transition phase. The body must rapidly re-establish biological autonomy, relearning how to maintain pressure, rhythm, and oxygenation without the aid of external mechanics. This chart tracks long-term success. The new plumbing alleviates angina symptoms in over 90% of patients within the first year. While atherosclerotic disease eventually progresses, survival rates remain high, 90% after 5 years and 75% a full decade after the operation. Stopping the heart is a violent intervention, but by utilizing harvested biological conduits and layered backup systems, surgeons can overhaul a failing engine and extend its functional life for 15 years or more.
If you like this video, give us a thumbs up